Um, Hello, thank you for the invitation. It's really nice to be among peers and friends. I say always that the anesthetists are the best friends of the perfusionists and vice versa. So I'm going to be talking about the protection of the brain during cardiac surgery. And why is this so important? Because patients grow older and they grow sicker. They have many comorbidities, and this does not concern only the cardiac surgery, but also concerns other types of surgery. There's a vast neurologic disorder spectrums, starting from postoperative cognitive dysfunction and ending at delirium. There are various mechanisms, the embolic emboli from lipids or thrombi, the perfusion pressure that you were talking about right now, the comorbidities, and the status of the patient before the operation, actually the brain status of the patient, and also the series that the patient essentially gets into when he gets into the operating theater. As we can see, there's a vast incidence range. We start from 1% up to 70% of patients having some kind of a brain damage. And the postoperative cognitive decline up to a year after the operation. Up to 20% of patients after a year of their operation, they have a cognitive decline. And we can see that when we speak to the next of kins, and they say that our grandfather or our father is not the same afterwards. This has raised concerns from the early ages of anesthesia, from 1887. And they said that they were noting that after the anesthesia, the patient has delirium. There are many etiologic factors. Not one of them is actually the key player, but all of them play a small or bigger role in maintaining the brain status of the patient. So there are patient-related factors, procedure-related, anesthesia-related, and or surgeon-related. As far as the embolic load is concerned, we have air, atheroemboli, thromboemboli, in particular, particulate emboli that come from the effusate of the thorax. And they are to blame for about 75% of actual strokes. Now, the atheromatous emboli, of course, we all know that an atheromatous ascending aorta, especially the lesser curvature, is a risk factor for cerebral emboli. Actually, it is the preview of a bigger picture. Even if we avoid dislodging these atheromatous emboli, the patients do not essentially have a better outcome. So what are the protective measures that we could use in such patients? Of course, statins are a key player. They do not make a difference when we start them perioperatively. They have to be started earlier on. And many have argued that we should start also aspirin or oral anticoagulants. As far as the aortic ultrasound, either epiaortically or transesophageally, we can see, we can define the place where the plaque is, and the surgeons will modify their technique. But as I said, this with various studies coming after this epiaortic era, of course, the surgeons have changed their approach concerning the cannulation or the aortic close clamp employment, but the results are essentially the same in the patients, because, as I said, this is a systematic disease and not a local one. So there are many techniques that the surgeons can use. Of course, the off-pump cardiac artery bypass, alternate sites of cannulation, using a deep hypothermic arrest, using a single cross-clamp technique and not a partial ones, or a movement of the clamp, and also use of cannulas that can catch this embolic material. So another question is, if in patients that have carotid artery disease, should we intervene or not? Again, the guidelines are not very specific. Of course, everyone agrees that in symptomatic carotid stenosis, then we should, before the bypass, intervene. But in any case, we should be using a multidisciplinary approach with and liaise with vascular surgeons and neurologists to make a decision whether to intervene in the carotid artery or not. Because as we can see in many studies, there is an increased risk of stroke and mortality in patients with carotid artery disease. But even if we intervene the danger is still there. As I said, it is a preview of a bigger picture. So as far as the thromboemboli are concerned, thrombi really start to form microthrombi in the circuit, regardless if we have heparinized the patient enough. They can enter the bypass circuit from the thoracic effusate, even before the use of heparin. And we should never forget that the patient after the operation is in a hypercoagulable state, which remains up to 6 months afterwards. And the infections are an independent risk factor of increased thrombotic material. So as far as the air emboli are concerned, I heard the previous speaker talking about the air emboli. Of course, we should be meticulous in de-airing the ventricle before removing the cross clamp, or we should be using CO2 insufflation in the surgical field. As you can see on this picture, this is a DSA, dynamic spectral array monitor, and a patient with virus. An overzealous CO2 insufflation. This comes to what Dr. Kotoulas was saying before. An overzealous insufflation of CO2 in the surgical field actually did a burst suppression of the patient, because there was a CO2 narcosis in the patient. So when we saw that, we decreased the insufflation rate, and the patient again returned in his normal state. So as far as the particular emboli, they come from the pericardial suction aspirate. There are lipids, there are bone, there's thrombi, there's complement activated factors, and there are many. There's a big discussion about that. The use of cell saver, for example, all the cell saver fans, the off-pump cardiac surgeons, or the micro extracorporeal circulation fans say that this cardiotomy suction actually, after the processing of the blood, this blood is devoid of emboli. But this is not the case. There have been several studies that show that the embolic load is exactly the same in the cell saver processed blood. And also the increased use of cell saver gets the patient in the danger of dilutional coagulopathy. There has been a proposal of using a 21 micron arterial filter in series with the cardiotomy reservoir, which could solve this problem. Now, the bypass time, of course, it is a concern of everyone. There have been many studies. Actually, this big study in 2003 said that CPB time more than 2 hours is an independent factor for brain injury. And these people actually were the off-pump maniacs. So, but afterwards, we saw that there are inconclusive results in off-pump cases, which means that the bypass is not the only thing that matters in the patient. The bypass is not the sole factor that does the damage to the brain. Also, patients with off-pump cases, they also have problems with perfusion because of the manipulation of the heart and the blood pressure fluctuations. You've talked about the perfusion pressure, so I don't want to get into that. I would like to stress that the transfusion rates should decrease, because the transfusions, the overzealous transfusions, are an independent factor of many problems. One of them is the brain damage. After in this big review, they saw that after adjusting for all the other confounding factors, they found that there was a 50% higher odds of brain injury. So the American Association of Blood Banks, and this is agrees with the European Association, states that 8 grams per deciliter is an acceptable level of hemoglobin. Nevertheless, as I heard also in the first, lecture, we should be keeping hematocrit during the cardiopulmonary bypass at least 20%, because of the oxygen delivery. Hypothermia seems to be protective of the brain. It induces coma. If we use a DSA, you see that there is a complete cessation of brain metabolic activity. And this burst suppression has been associated with a postoperative cognitive decline, but actually hypothermia is protective. So we cannot really stress which is which. What can an anesthetist do? First of all, we can have various monitors. To break this to you, no excellent monitor exists. We know that. And these monitors really do not make by themselves the difference. The difference is that these monitors keep us next to the patient and keep us in connection and in communication with the perfusionist and the surgeon. There was a really outbreak of NIRS monitoring the regional saturation of the brain. And in the beginning, everyone was talking about regional abnormalities in the oxygenation and postoperative delirium. Actually, this big research article showed that they gave actually an actual cutoff value of 50 to 55%. Nevertheless, this hasn't been backed up with data. With strong data, and the American Society for Enhanced Recovery says that, okay, it makes sense to use NIRS in the patients. There are weak recommendations, but it makes sense. In a recent article of in the Journal of Cardiothoracic and Vascular Anesthesia, they argue that NIRS does not make a difference. What makes a difference is the actual state of the patient preoperatively, the preoperative cognitive impairment, whether we use or not dexmedetomidine, whether we have a big cardiopulmonary bypass, and whether we have values of BIS, the bispectral index, less than 40. So this is our new era of BIS and dynamic spectral array. This is very hot nowadays in the anesthesia societies. We can see with this monitor, we can see the state of the brain before the operation. We can see the state of the brain during the operation, and we can decide whether the brain is aged for the biological age. And we can also guide our hemodynamics and oxygenation through this monitor. In this case, it is an actual case. You can see this line that. You see this line that goes, this vertical line. This is an actual VF in a patient that was in an off-pump cardiac surgery during the grafting of the anterior descending. And he suffered a VF, which was promptly reversed. So you can see that there was a cessation of brain activity, of brain metabolism, and then this afterwards continued normally. In this picture, you can see that you have the so-called burst suppressions, these blue lines that span the whole spectrogram, and these are moments where the brain has no metabolic activity. And also in this region, this is, I'm just telling you just to see, this region is the alpha waves. If we don't have alpha waves, or we have weak alpha waves in the patients, then this is a sign of an aging brain. This all is really, really nice. This makes us feel smarter. But unfortunately, a big data come from robust studies, and they show that there is no etiologic connection between low BIS values or EEG suppression with delirium. And a recent study tried to combine both DSA and NIRS, and of course, in areas where there was, in times where there was a low NIRS or low oxygenation, there was a low DSA. So this is nothing new there. The transcranial Doppler, I have no experience in that. Then, if you use it, you can see the perfusion during the bypass or during the periods before and after bypass, and you can actually find. You can detect microembolic signals. As far as anesthesia is concerned, we have done everything. We have compared volatile anesthetics. We have compared intravenous anesthetics. We dug up ketamine to use it. We used opioid sparing techniques. Nothing has really been a game changer. Dexmedetomidine is one very promising pharmacological factor, and after the bypass, after the operation in the ICUs. If you remember, there was a study before that said that dexmedetomidine was associated with less cognitive decline afterwards. As far as the tranexamic acid is concerned, of course, we know that it can lower the seizure threshold. And what we do is this is not with robust evidence-based decisions. We avoid benzodiazepines, we avoid anticholinergics, tramadol, antihistamines. The ERAS protocols claim that we should monitor brain quickly, so we should wake the patients up really quickly and see if there is any brain dysfunction. We should try and spare the shed loads of opioids that we use, but not take them out. What is really, really important is to anticipate the patient that is going to have a postoperative decline, delirium, or a stroke. Concerning the postoperative cognitive decline, which is again the hotspot of anesthesia, as you can see, the strength of evidence is the only strong strength of evidence is the increased risk patients, the aged patients, the patients that have previous stroke, or they have a decline during their discharge. All the others, as you can see, are weak or moderate evidence. So as far as the neuropharmacological methods, we should establish a baseline status of the patient with cognitive tests. There are very many cognitive tests that we can use, and these ones we can use after the discharge of the patient in due time, 3, 6, or 12 months, and see if the patient has declined or not. We should always keep the patient safe and provide him with his visual or auditory aids. We have to have their next of kin present in the postoperative ICU or in the ward afterwards. The patient should be oriented in time and in place. We should adhere to his circadian rhythm and have a quiet environment, and of course, feed and hydrate him. That's about it. Thank you.
Thank you, Chris, from the excellent presentation. And we call Eftikos Panagiotis, doctor, cardiac anesthesiologist of Onassis Cardiac Center, for a comment.
Thank you. Well, hello, thank you for the invitation. It is a great pleasure to be here to comment on Dr. Apostolidis' presentation. Indeed, neurological complications remain among the most worrying problems after cardiac surgery, since these complications not only impact morbidity, mortality, also deeply affect a patient's quality of life. As Dr. Apostolidis said, the brain injury during cardiac surgery is multifactorial and results from different mechanisms, such as embolic phenomena or systemic inflammatory response or metabolic phenomena. The strategies used include pharmacological agents like ketamine, dexmedetomidine, and other, and procedural impacts such as controlling temperature, reducing cardiopulmonary bypass time, monitoring cerebral oxygenation and cerebral perfusion pressure. However, as Dr. Apostolidis rightly emphasized, the evidence is inconclusive in many areas. For example, while some studies suggest that volatile anesthetics offer neuroprotection over total intravenous anesthesia, other studies fail to improve difference in long-term outcomes. Importantly, some neuromonitoring tools like near-infrared spectroscopy, NIRS, so to have potential in real-time detecting cerebral hypoperfusion, and these monitoring tools are not universally adopted. So this is an area where standardization and wider implementation could make a difference. Another factor under-recognized that I would like to highlight is the psychological dimension of illness and recovery in cardiac surgery, and especially the presence of depression in elderly patients. Depression can be present preoperatively or develop in the postoperative period, very often remains undiagnosed and untreated, and can cloud the clinical picture, especially in elderly patients, by mimicking cognitive decline and memory decline. So where do we go from here? In my opinion, the future lies in personalized and multimodal ways of neuroprotection, including risk assessment, neuroprotective agents, real-time monitoring, neuromonitoring, wider use of neuromonitoring, and tailored perfusion strategies. Well, thank you.
Thank you.
Thank you very much.
And have quicker and more elegant surgeons.
Thank you very much,
Thank
Christos. Thank you all. I want to thank all the speakers for their excellent presentations. This was our last webinar for this year, and I would like now to call our head of perfusion, Athena Ramu, to make a comment. Athena, here, please.
From my point, I would like also to thank you all for your time, for your participation in our webinar. I just want to make a comment. When I first read Gravely's book, The Perfusion Bible, in the chapter about the history of cardiothoracic surgery, it says that 100 years ago, the cardiac surgeon, if he had to operate a heart, if he had to open a heart, the only thing that he could do was pray. Then after the discovery of the first bypass machine, I believe perfusionists were blind, were trying to bypass the blood from the heart so the surgeon could operate, but had no tools that they could perform the perfusion. With the progress of the technology, we could take photographs of the condition of the patient, blood gases, or every 30 minutes, so we could have just an image of the condition of the patient. Nowadays, with real-time monitoring, all the different kinds of monitors that anesthesiologists use, and also with the goal-directed perfusion, I believe that we can see live and watch the condition of the patient and what our actions interact with the patient. I'm looking forward for the future to come, when all those monitors, all those values will be connected with the help of AI and will help us make the right decisions for the certain patient. I believe today is a really good example of the progression of the technology and the importance of sharing information and continuously be educated. Vicky, you did a really good job. Great scientists from all around the world, very specialized in the field, gathered together and gave us information about the right way to do things in perfusion. So I hope that we will continue to do that, and continuing education is really important. Thank you. That's it.
Thank you all. Ευχαριστούμε όλους που ήρθατε.
Απλώς να σας πούμε ένα πράγμα, ότι του χρόνου